Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Leadership Lessons in Ambulatory Care Service Development from High Performing Health Systems call. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Jill Keyser. Ms. Keyser, the floor is yours.
Thank you. Hello, everyone. This is Jill Keyser-Anderson with Stratus Health, the Minnesota organization that is part of the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to this educational session entitled Leadership Lessons in Ambulatory Care Service Development from High Performing Health Systems. As mentioned earlier, this session is being recorded and will be available on the LSQIN website at www.lsqin.org in about 2 weeks. Names will be muted during this webinar. However, after the presentation, we will have a time for questions, so please make a note of any questions that may come up as you listen, and/or feel free to write your question in chat, and we will pass that on to the speakers. We are pleased to have Todd Sorensen, Amanda Brummel, and Dan Rehrauer as our featured guest speakers today. Dr. Sorensen is Professor and Associate Head of the Department of Pharmaceutical Care and Health Systems at the College of Pharmacy at the University of Minnesota. He also serves as the Executive Director of the Alliance for Integrated Medication Management, a nonprofit organization that engages healthcare institutions in practice transformation activities that support improved medication use. Much of Dr. Sorensen's work over his career has focused on leading practice change and the development of future pharmacy leaders. Dr. Sorensen's scholarship activities have focused on identifying strategies and leadership activities that have led organizations to successfully integrate and sustain medication management services. Much of this work has stemmed from years of experience participating in and leading a national quality improvement collaborative for health systems seeking to optimize medication use in outpatient settings. Dr. Brummel serves as the Director of Clinical Ambulatory Pharmacy Services for Fairview Pharmacy Services. In her role with Fairview, she has built and practiced medication therapy management, also known as MTM, in multiple clinic locations. Currently, Dr. Brummel has responsibility for the MTM program, the clinical development and integration of pharmacy services in the Fairview Health Network, including the transition of care approach and retail clinical services. She works closely with the Fairview Medical Group and the Fairview Network in Population Health Program and New Payer Product Development. Dr. Brummel is an adjunct associate professor at the University of Minnesota and has chaired and served on committees with the Minnesota Pharmacists Association, the American Society of the Health System Pharmacists, the American College of Clinical Pharmacy, and Pharmacy Quality Alliance. For the first 9 years of his career, Dr. Rehrauer practiced and built ambulatory care practices. Over the past 5 years, he has worked with HealthPartners, which is an open access health plan and network of clinics and hospitals, managing and expanding the MTM benefit and providing direction for pharmacists employee services in ambulatory care clinics. He is active in the Pharmacy Quality Alliance, working to develop medication use measures that demonstrate high-quality care. Dr. Rehrauer is a well-known local and national speaker. Welcome, Amanda, Dan, and Todd. Thank you for being with us today. I will now turn the presentation over to you. Todd?
Hello.
Hi, is that Todd?
Yes.
Okay, we're turning the presentation over to you now. Thank you.
Okay. Can you hear me?
Yes.
Okay. I was saying that we're excited to be here with you and share some of the lessons that we've learned over the years regarding how to establish medication management services as a sustainable part of a ambulatory care program. So for this presentation, the questions that are running through our minds as we engaged in this work and put this presentation together are here with you. We want to address what we feel is some of the most critical element of success in medication management programs. We want to have us thinking about what can we learn from the innovators who have achieved early success, and then how do we create an environment that accelerates adoption of systems and to support optimal medication use. The way we'll go about that today is I'm going to provide some background and framework for this topic. Then we will be going through some results of a project that we were all a part of, and I'll be turning it over to Dan and Amanda at various times to share their personal experiences in their organization that will give you the stories and the details that are important to understanding the concepts that have emerged that drive success. As we get started, I want to first have us think about meeting society's medication needs, and really we know a lot of statistics around what's going on with medication use and how it's less than optimal. The money it costs, the harm it induces, and the chronic care that is goals that are not being achieved with optimal use. But when we look at this line represents my idea of scientific knowledge regarding medications and their use. Over the last 2 decades, it's just really exploded, the amount of scientific knowledge that's there. Combine that with the needs of society. As our technology has increased, so has then the complexity and the needs around it. And medication use is the most common intervention for managing chronic health conditions. And then when we look at the knowledge that we convey to pharmacists and graduates, and really all providers, our knowledge and skills are pretty well keeping up with these 2 areas. But when we look at the role of pharmacists in a typical pharmacy practice, it unfortunately is not keeping pace with the expansion of knowledge, the needs of society, and the knowledge that they possess. And so the question for us to be thinking about is what is required to close this gap? How will we bring these lines in parallel with each other rather than continuing to diverge? And to think about that, I would share with you something you may be familiar with, the diffusion of innovation curve, which highlights how a new idea, a new service, and an innovation develops and spreads across a community and becomes permanently embedded across that group. And we need to think about this and understand this as we think about expansion of medication management services. And when we look at these categories, everybody falls into one of these types of categories here. And show them all to you here and quickly walk through them. And innovators are really interested in anything new. They are filled with ideas, intrigued by ideas, and often are on the edge of things that most people don't believe are actually going to come to fruition, and can often be dismissed. But every now and then, some of the things that the innovators develop will then be picked up by early adopters. And these are the individuals that are also very interested in ideas, but they become a very influential source in the spread of these ideas. These are well-connected individuals. They hold, they're integrated into social systems that help with their influence. And so for an idea to stick, it's largely dependent upon the work of these early adopters. The early majority is the group that's sitting there thinking that this might be a good idea, but they're not going to jump in yet until they see the evidence that this is worth their time and energy to do. And then finally, the late majority are the group that really have to have some sort of pressure put on them to adopt. And finally, the laggards are not going to come along unless they absolutely have to, that they'll either be kicked out of the environment that they're in or will simply not be able to exist. And I think an example of this that's used sometimes is that if we would still allow people to have rotary phones, these are the people that would have them, that they wouldn't want to adopt that technology. And so it doesn't do a lot of good to focus on individuals on the back end of this curve when you're trying to grow a new service. We need to be focusing on the front end. What we need to achieve is hypothesize that in order for an idea to stick, for an innovation to become permanent, we need 16% of the population to adopt that. That's that innovator and early adopter group. Once we hit that 16%, that's when we start moving into the early majority. They will have seen enough evidence that gets them to buy into this, and come along with the rest, and the curve can continue to progress. But until you have 16%, the innovation, it's unknown whether or not it's going to stick or not stick. And so when we're thinking about the expansion of medication management services, do we believe that we have achieved 16%? That 16% could be defined as 16% of patients of need who have an opportunity to experience it, 16% of those who could deliver the service actually being able to do it. However you want to do it, and I think in either one of those cases, it's pretty clear that we've not achieved that level to create a tipping point yet. So how do we get there? A quick statistic from the American Society of Health Systems Pharmacists, nearly 80% of participants in the Ambulatory Care Summit that was convened believe that organizations are looking for guidance. They aren't necessarily those innovators that will figure out the guidance on their own. They're looking for from others to take their cues. And so we need to go and study them so that those who are looking for that guidance will actually have it available to them. And so that's where we're going to get started with the work with Dan and Amanda today, is as we look to solve many of the problems we have in our society around medication use, we need to look at those who have found ways to adopt the systems that are making that happen. And so the basis of this presentation will be covering a research project we did that looked at 6 Minnesota health systems with robust medication management programs. We did focus groups through qualitative research methods, went out and interviewed the teams in these organizations. That included pharmacists, it included medical staff leaders, included administrative or senior executives in some cases, quality improvement personnel. They all came together to describe their story of how they got from where they started to the point where they are now. We applied thematic analysis and came up with a series of lessons that were learned. And the result of this is that we can identify what works versus identifying the barriers and challenges which don't help us get to solutions. And what this really is then is leadership guidance for the early majority. For those who are sitting and looking for that guidance, this is what we're trying to produce. And it really is leadership stories that we heard from these organizations and then categorized into different areas of work. Why these 6 organizations? When you look across them, they have many years of experience doing this, and they have adopted this service across many clinics. So across the 6 health systems that were a part of this project, 89 clinics had medication management services formally integrated into them. They have over 80 FTEs of pharmacist time committed to this work and over 62 years of experience. And across these organizations, they're producing nearly 50,000 encounters per year. That gap that exists, I asked the question, what's going to close it? Our argument would be that gap is a leadership gap. It's not a knowledge gap. It's deeper than that. And so in going about this project, we used Cotter's leadership model for organizations change to explore how these organizations created the change individually. This model just shows you an overview of what that looks like. There's 3 major areas of work in a progression that an organization needs to go through. They create a climate for change. They engage and enable people across this organization and bring resources to bear. And then finally are able to implement and sustain that change. And I won't get into each of the subcategories there, but this is a well-established model that's been around for about 15 years and is a guide for organizations on how to lead significant change and produce sustainability of that change. And this is the basis for the interviews that we did. So when we look at what we found, it aligns with this model quite well. On the left side of this diagram, you see the 8 steps of change as defined by Cotter. In the middle is the 3 stages of change. And on the right side is the 13 themes that emerged across those 6 health systems and the focus groups that we did. And what we'll be doing for the rest of this presentation is going through a number of these and having Dan and Amanda kind of share with you the story behind these words. What did this look like? What did it entail? And how did it lead to their success? Why was it that story that they told us in these interviews? Because they had identified that in their reflections of what made them successful as a critical element of their success. So to get us started with the first one of the first things we identified is these organizations were compelled to change because of some sort of external influence. This is the definition of that theme that we identified. I won't read it entirely to you, but the core idea here is that change occurs not because, in these cases, entirely because internally inside the pharmacy department they wanted to happen, but they were responding to an external influence. And to give you more detail about what that looks like, I want to turn it over to Amanda and share some of the story from Fairview about those external influences that led to their initiation of this work. Amanda?
Thanks, Todd. Good afternoon, everyone. So with this, and to give a little bit of background for those who may not know, Fairview has been providing medication management services for the past 17 years. And really with this external influence theme here, it really began with us when Fairview and the University of Minnesota partnered in 1997. And through that partnership, we had a closer working relationship with the College of Pharmacy, who was really pioneering a new practice model called pharmaceutical care. And in that practice, they really wanted sites to be able to set up practices where students could learn this new philosophy of practice that they were teaching. And so that was a huge external influence within our organization to kind of bring the teaching aspect from teaching the students to create these new practices and pioneer this new practice model through our work together with the university.
All right, thanks, Amanda. And I hear in that example some of the language that's clearly about innovation, that you spoke to both organizations really having that idea. So getting back to that diffusion of innovation curve, both of those organizations were focused on being an innovator in this environment. Now, the second theme that emerged was in these health systems, someone in the organization began to identify pharmacists as an untapped resource. And so the definition of this, emerging across these different organizations, was that it was identified that there was a need in that organization, there was expertise that was there, and it wasn't being utilized, and a desire to try to make that happen, create that connection. And so I'm going to turn it over now to Dan to talk about HealthPartners' experience and what that untapped resource, how it was identified, and how that led to some of their early work. Dan?
Thanks, Todd. Just in case some of you are not aware of HealthPartners, HealthPartners is an integrated organization. So we have our health plan, have care delivery as well as hospitals, and have pharmacists involved in all of those areas today, but it didn't start out that way. For many years, pharmacists were working hand in hand with physicians in our hospitals, and leadership really, I think, noticed that pharmacists weren't being utilized to their full capacity in an outpatient setting. And because of that, we were ending up with, good medication use inside the hospital, but then when they went home, we weren't having the same involvement. People were having poor medication outcomes, and they felt that pharmacists really could play a role there like they did in the hospital. So the first seeds were kind of planted, really small. We had pharmacists who were brought on and weren't visible in the clinic, but were working behind the scenes, sort of at the health plan level, advising some of the prescribers related to lipid medication use and ways that patients could be served potentially better in the background. And that really laid the groundwork for our first ambulatory care services in 2006, when our state Medicaid program and Medicare Part D required MPM to be covered for our members. The move to integrate pharmacy services into the clinics was really a natural progression as a result of that early work.
All right. Thank you, Dan. Interesting how different parts of the organization can identify things, and then do you have the leadership ability in that organization to bring those together and to create something? So as we move on to the next one, the principles of professionalism, this gets to really part of the genesis for this project in the first place, is that I knew that many people were aware that in Minnesota, Medicaid paid pharmacists for medication management services. and that there potentially was a belief that that was one of the reasons why, or a primary reason why, some of the opportunities for expansion of those services were in place. However, talking to people like Dan and Amanda, I had the sense that that really was not a driving factor, but I didn't have anything besides anecdotal evidence to support that. So going into this project, we wanted to know, was money a driving force or was it not? And honestly, money never actually came up during these interviews as one of the factors. And I think that's true of those innovators and early adopters. They do things because they're interested in the ideas, and they're not necessarily about receiving some sort of reward. And so talking about the issue of principles of professionalism, it came out in these interviews clearly, and specifically I'll turn it over to Amanda to talk about how this was really articulated across the organization when this was started.
Yeah, so when we talk about this, I mean, I think, again, going back, and giving a little bit of history, definitely from a financial standpoint, we didn't even have pharmacist services that were really covered when we first started this. And really the feeling was that this is where the profession needed to go. This is where the profession would be going, and we wanted to help to create that change of where the profession was, needed to be led in that way. And in working with our chief medical officer and our CEO at the time, the vision was absolutely there that this was the right thing to do for patients, that patients needed to have a pharmacist as a part of their team, and that we should be looking at their medications to ensure that they were, indicated, effective, safe, and convenient for them. And it really wasn't a budgetary decision. And I think, again, going into kind of creating that climate, it was our medical officer who was really our first champion in bringing this into the clinics, and at that time our organization was going under change with our clinics too, and kind of developing their own medical practice structure, and really wanted to get this into the clinics and help break down any barriers that were needed, for us to do that. So she was really a champion in that way. And then again, that deep, profound feeling, I think, of this is, from a profession standpoint, where we needed to go. And our group, I know we had gotten together, we had a vision, that we had a timeline, that we wanted to be recognized for being a part of the paradigm shift of pharmacy, and that's what our team believed, and that was a main driver of our practice and the decisions that we made, and other things that we'll continue to talk about in this webinar, was because, again, we really felt this was where the profession would end up, and we still believe that.
So getting back to the idea of leadership being the primary ingredient, I hear that clearly there. I hear words like vision, a commitment to that vision, and doing what's right for the patients in a patient-centered model. And so clearly leadership from all levels of the organization making this happen in that case. Now if we move on to the final theme that emerged under this concept of creating a climate for change, allowing the organization to see the need for change, it comes down to organizational culture. And we heard this consistently across these organizations, and as not just in pharmacy, I think in other areas, they would be classified as innovators and early adopters, and it was part of their environment. And I specifically remember that coming out of the conversation with HealthPartners, and so Dan's going to tell us about how this culture really drives change across their organization, how important it was to this particular change.
Okay. So HealthPartners, our vision, health as it could be, affordability as it must be through relationships built on trust, is really grounded in the triple aim for healthcare. We are trying to make sure that people are as healthy as they can be and have the best possible experience related to their health care at the lowest possible cost. And just from a very basic level, the encouragement of innovation is very high in our organization. We are constantly encouraged to be looking for new and better ways to do things, how to do things differently. It's encouraged constantly. And along with that encouragement, there is permission to fail. there's not an expectation that every time we try something that it's going to work. But when it does work, it's moved forward quickly. And I think MTM is a very good example of that in practice. So Medicare and Medicaid required HealthPartners to offer an MTM benefit. And I think that happened with other health plans in the state as well. But from very early on, our leadership said, if this is good enough, or if it's offered to our government payers, why is it not okay for our commercial population? And really, almost from day one, there were plans in place to figure out, does this work in the commercial population? And pilots were started. And the results of those pilots were successful and gave us evidence to show that this really was something that was going to be a positive for our organization. And as a result of that, we've grown. We've grown the size of our in-house program, as well as growing the size of our provider network and the number of people that are covered by an MTM benefit.
Thanks, Dan. And I think culture is something that it takes a long time to develop, but once you have a strong culture in place that supports this, the ability for it to support the work you want to do is remarkably powerful, and we heard that consistently across these organizations. If we move on to the next general stage of change in organizations, we move into engaging and enabling the whole organization. We've created a culture for change, and now the leadership is really focused on engaging everyone who needs to be and bringing the resources forward that will support that to happen. And momentum champions, really, this was something I've been hearing anecdotally for years, and it certainly came out in this case, that just about every organization that was successful in these endeavors could point to somebody that they described as a champion for this work. Somebody at a senior level, decision-making level, somebody outside of the pharmacy department that believed in this and bought into this. So we would bring that forward as something that, if you're engaged in this work, identifying those champions is critical to your success. Now, Dan and Amanda, we didn't have a specific slide for this, but I just wanted to turn it over to either one of you to see if you, maybe you could just quickly tell us who was the most significant champion you remember, and why you thought they were that champion, or how you engaged them, if you could describe that briefly. Amanda, let's start with you.
Sure. So I think I already spoke a little bit about our Chief Medical Officer, who definitely was a champion in this work and believed in bringing this new practice into our clinics. And so she definitely was there and helped to promote that and bring that forward in the organization. I would also say, though, we had plenty of champions on our pharmacy side, too. Bob Beecher, who is the president of our organization, believed in this as well, and really, again, committed the resources to making this happen through our pharmacy budgets and other things. And so I think, and then, again, you can continue to go down kind of that leadership path of people believing that this is the right work to do and continuing to keep our philosophy of practice whole. So I think usually there's more than one leader, but I think, to what Todd said earlier, you have them both maybe within pharmacy, but definitely without pharmacy as well, and throughout the organization to really bring the support forward.
Dan, who was the champion that stands out in your mind going back to some of the early days?
And so, I think there are champions at all the levels. There were individual, physicians within clinics where practices were beginning to grow. There are certainly champions within pharmacy. Our vice president is a very big champion of the MTM program. And, hugely beneficial for our program is that our CEO is a huge champion of MTM. So we have it from the very top of the organization. So it has been incredibly important to the growth of our program.
All right. Now we'll move on to the idea of collaborative relationships and how important that was in producing the success. So existing relationships with providers and healthcare staff that facilitated the implementation of the medication management services. Every organization talked about how they couldn't do it alone. It had to be in partnership with others. And so, Dan, you talk about what these collaborative relationships look like and how they led to your success.
So, partnership is in our name, and collaboration is something that is really, truly a part of our organization's DNA from top to bottom. And really, I think it's key to our success. We know that we can't do things alone. We, as a payer, we rely on our provider groups to provide the best care possible. We are constantly looking for new ways to do things, and when we find things that work, we share that. We don't keep it under our vests. Our goal is to spread what we learn, and then our goal is to be the best at executing on doing those things that we learn work. Over decades, the people that have been attracted to work at HealthPartners are those people that thrive working as a part of a team. The people generally know quickly whether they're going to last at HealthPartners, and when they last for a very long time. We have lots of very long-term employees in our organization. The type of person that works here really there's less issue with turf, easier acceptance of new ideas, and MTM services are a great example of that. As MTM grew, they became integrated into primary care very quickly. But really, it grew beyond primary care into other areas of the organization, such as our disease management and case management and well-being areas, where really MTM has become integrated, and really it's an integral part of care delivery within our organization. I don't know that it could go away at this point because of how integrated it is.
All right. And then we continue along this. One of the words you used, Dan, was execution. So, and that's part of this general stage here is executing on the things that need to happen. Service promotion was one that came up as critical to success. Gets back into that collaboration, but really how you create that collaboration, not just with other providers, but it was described as important to be with patients and the financial stakeholders, spreading the service, not just communicating in the organization, but to beneficiaries in the case of HealthPartners and others. And Dan, you're going to talk about this one as well.
Yes. One of the, I think, early very smart things that was done was to offer, so when we talk about expanding into our commercial population, we started with ourselves. So an MTM benefit was offered to employees. And the people who had been hearing most about MTM prior to when this occurred were people that were in senior leadership. And senior leaders were some of the first who participated in the MTM program. And they had great experiences. As many of us who are in the world know, people love MTM. They just do, and it was a feather in the cap, because when MTM came up in all different areas of the organization, senior leaders had a positive viewpoint because they had personal experiences with it. That helped us. We were able to, it helped us in expanding the benefit. They wanted that same thing to happen to other parts of our membership. We wanted to remove barriers, and they were supportive of making sure that there was no copay or cost share, or ways that we could get to make sure that we were engaging as many potential people as possible to get this service. Like I said earlier, our CEO is a huge champion, and the program is regularly recognized, multiple venues, in communications at full company leadership meetings where MTM results and innovations are talked about in front of the entire leadership team. In written communications that go out to the organization, success stories. At a more local level, a lot of work is done to share the success of the pharmacists that are providing care in our care delivery. So we share information about how well are we doing keeping diabetic patients in control or vascular patients in control. Things that the clinics care about are Minnesota community measures in those areas, and showing that MTM is having a positive effect on that in order to help continue to increase referrals and continuing to keep MTM on the forefront. There have also been multiple campaigns to improve the public's recognition of programs, and we've still got a long ways to go, but it continues to be an important part of the organization. And one sort of anecdote that I have, one of the first meetings when I came to HealthPartners, so I'm a pharmacist and providing MTM, and no one in the world knows who MTM is outside of pharmacy, or that's what I feel like. And one of the first meetings I sat down in had people from sales and from benefit design and claims, and everyone in that room knew what MTM was, and I was just absolutely floored. I couldn't believe that people outside of pharmacy really knew what MTM was, and it really is the case that across our organization you can run into almost anybody and they understand what MTM is.
What I hear in that is really the breadth of the communication, Jen, and it sounds like it became almost a campaign across so many different groups and stakeholders. It wasn't any one group, and it really supports the idea that you probably can't over-communicate when you're trying to produce something new like this. So thank you, Dan, for that. Now if we move into our last one on engaging and enabling the whole organization, we talk about team-based care. When we talked about collaborative relationships, it was probably more from an administrative standpoint, thinking about collaborative relationships. I think a little bit was touched on with team-based care, but this theme was really more specific to that. The frontline practitioners working together as a team and what that meant to the success. And so I'll turn this one over to Amanda to talk about how important that was in Fairview's growth period.
Yeah, and I'm sure that many of you on the phone are also experiencing this within your teams. But I do think that we talk a lot now about having team-based care. But again, going back 15 years ago, I think that this was a pretty new concept within some of the parts of the organization, again, of where, physicians really felt that they led the work. And so I feel a piece of this, we still grow this with today, but really was bringing in those extra team members. And you're going to hear me talk about this in an upcoming slide as well. But part of how I think this became very successful for us in our organization was that medication therapy management or pharmaceutical care, when we first started this work, it had one meaning. And so our team could grow and the teamwork solidified because everybody understood the roles of each team member and what we were all bringing to the team. And so I think in having that clear definition of what we were providing our patients and the consistency that we carried that out with, we had success in being able to build our team. Dan also talked earlier about having local champions, and I find this, and I had the pleasure of being able to start many practices myself within our organization, and I see this when we start new practices still today. You have that one or two physicians that you first start out with. They get it. They're the early adopters. They understand and they utilize you and bring you into the team. It's fitting into the work that's going on into the population, caring for the patients. And again, I think understanding and having that clear role is so important. And I've seen this continue through our time in the organization as well. And it's not just the direct patient care that we do, right? It can be the care conferences that are had. It can be developing of clinical pathways, where our pharmacy teams are asked constantly to be a part of the team in developing and furthering the work that happens within the organization. So, again, I think, bringing a consistent and solid role of what each member was going to do, but then again, working for the good of the patient and for the good of the team has continued to make this successful.
You said you were going to speak to the next slide a little bit there, so we'll just move right on to that and have you pick that up again as you talk about the work of the team and those practitioners working together, not only in patient care, but you described some of the administrative work that needs to happen in clinical pathways and things. But you alluded to the importance of a consistent delivery of this model across your organization, and that's really what we heard and we called supportive. Oh, I'm sorry. I'm going to I'm on the wrong slide. Creating the consistency and documentation of the standards that are necessary to support that team-based work. So we move on to picking up, Amanda, where you were talking there to talk about your care model and how important that was. You've alluded to that, but how that led to some of the additional elements that allowed the efficiency in the practice.
Yeah. So I think, again, if you go back to the time frame that we started, there were no rules across our state with Medicaid, nothing defining what needed to be done or to have anything to link on as that standard of work. We had really the philosophy of practice in the pharmaceutical care process that we looked to and became our standard of what we did. But again, that was really being initiated at the university and not well laid out at all into even pharmacy practice, let alone physician practices. And so it was really key and important that when we went into the practices, we knew what we were bringing to the team and we knew our role within, the work that we were doing. And it was very easy, I think, and we were challenged often very, early on about, well, could you help us with prior auths? Could you help us with patient assistance? Could you help us with, X, Y, and Z? And although those things can be beneficial to patient care, they can be good door openers into what, trying to get yourself situated into a practice, I think at the same time it was critical that we drew the line of what our role was in those areas and the type of professional that we were bringing to the practice, and also, what it meant when we saw a patient. And so we would invite people into those visits so they could experience a pharmaceutical care visit within that, and they also heard from the patients, and there was the word of mouth with that. But really having that consistent care model, because that just brings, of course, dependability, again, to practices. And it's one thing if you're one clinic and you can kind of create that dependability in your clinic, but we had 45. So we needed to make sure that that model was thought of as the same in all of those different clinics. And so we, developed a practice model around that. We had an operations manual that we used to, again, kind of set those and define those clear roles and expectations of what occurred during that time. Also, you can see with a specific documentation, and we're going to talk about reporting in a little bit as well, but again, having those consistencies, and we've done different things over the years, going back to providers and saying, what do you want to see in the note? How do you want to see this? Making sure that we were kind of checking the same medical standards that our physician colleagues were checking with to make sure that our documentation covered all the bases that it needed to have as well. Making sure we fit into the system with the other standard processes. The worst thing that, in my opinion, that you can do is to create a separate process that doesn't fit into the workflow of anything else that the providers are doing. So making sure that referrals were easy, that they knew how to do it, making sure that appointments could be made in multiple ways but convenient to both the provider and to the patient. Understanding and letting people know how were we going to communicate with them. And again, at that time, we were in a paper chart world. And so, what kind of notes were they going to see? How were we documenting? What was going to be there with the EMR world that became much easier? So, billing, collaborative agreements, things there too about setting up a structure and making one collaborative agreement to be utilized across our system so that providers in Clinic A didn't have a different experience than providers in Clinic B. So a lot of kind of creating that consistency across practices was so critical and important, I think, for us.
As I hear you talk, it really sounds like a story of maturity and understanding how the rest of the system works and adopting those same principles that have been established elsewhere and not feeling like the pharmacy service can be any different than any others, and that maturity had to come along quite rapidly in order to continue the growth curve. So the last item we're going to cover here, we're going to, in the interest of time, not focus on sustainability strategies, but we can't end this discussion without talking about the importance of measuring and reporting results. As I've seen this over and over again, those organizations that are able to grow, it's because they usually have the data and the stories which justify that, and those that are doing good work but have not taken the time to measure probably are not going to have as much success. And this came out in the interviews, not just clinical data, but also looking at patient satisfaction and other measures. So for this one, I wanted both Dan and Amanda to comment briefly before we move into the question section of the session to talk about the importance, how, not necessarily everything that you measured, but how that measurement strategy that you adopted was important in building coalitions and growth with other parts of your organization.
Yeah, so I can go ahead. I'll start, Dan. I think really I think of this as a feedback loop and mechanism. I mean, we really needed to be able to show the practices what we were doing and to show our leadership what we were doing. And so this started out with just really reports on the practice and how we would deliver those to each clinic. You know, how many patients we were seeing, what types of problems were we finding, what were the most common conditions that were being referred to us. We did some work and utilized a system that helped us to estimate some cost savings. So, you know, those were some of the beginning clinical, in air quotes, type of work that we did. Then we also wanted to see how do providers feel, how do patients feel. You know, Todd mentioned patient satisfaction. That's a big piece across our organization in general. That's something that we did early on that we knew we could measure and be able to, again, feed that back. And then this progressed over time as we began to have more clinical goals, as the systems began to have more clinical goals. We started reporting out on those as well so that, again, we could show the impact of our service. We worked hard, I think, to publish a lot of our results as well and had partnerships with others to help us to do that, again, to try to bring focus to the practice and to be able to show that we could and we're making impact on clinical, humanistic, and economic resources. Dan?
You know, I echo what's being said. Having data is incredibly important. And I think it's important to have the data that your organization cares about that crafts the story that your leadership needs to hear. There are multiple ways that the story can be told. At HealthPartners, it's the triple aim. So we focused on those three outcomes. Initially, I think experience was the easiest one for us to show because you have almost immediate feedback. You have stories right away that about what you were able to accomplish and what a patient said or what they wrote. And so early on you have that, you know, that initial indicator of success and then work over time to have the clinical results and work over time to have the cost results. And over time they did come. But focusing on crafting that story the way that your organization, what your organization values and what your leadership needs to hear.
All right, thanks, Dan. We're going to just close the loop on this and then see if there's any questions. And we went through this material quite quickly, we understand, but it's available to anyone who would like to see it in more detail. And so this slide here just shows a report that everyone can access on the Internet. We took these focus groups and we turned these spoken leadership stories into written leadership stories. And each of the health systems that were a part of this group has a case study that was developed. You can either download the document that has all 6 of them, or look at the individual ones. So the 2 that are pictured here are the case studies for HealthPartners and for Fairview. So looking for more detail, I would encourage you to look at that. We also have a paper that will be coming out soon. We don't know exactly when yet, but shortly in the American Journal of Health Systems Pharmacy that describes the research methods behind this work. Lastly, our takeaways for today. We hope that you realize that the opportunity for medication management services to impact health is dependent upon committed and effective leadership. It's not the clinical skills per se that are going to drive this change. It's the ability to lead a group of people and an organization through the process of change. And that's what this work is intended to do, is to help provide that roadmap. Innovators and early adopters are the ones that are going to lead the way, and we need to learn from them. We've heard from 2 on this call. There's 6 in this report. There's others that are out there that we need to glean the lessons learned from them so that others can accelerate the change that they're trying to create. And then finally, some may be familiar with the ASHP Ambulatory Care Summit recommendations. We didn't really find anything in this report that was significantly different, but I think it adds a lot of detail to what was proposed and recommended through that. So we would highlight that report as another resource, but that this one helps provide some of the tangible actions of organizations that have followed some of the recommendations of that report, although they were doing that before the report was released. So, Jill, that concludes our comments. I'll turn it over to you to bring us to the end.
Thank you very much, Amanda, Dan, and Todd. We now have time for a few questions or comments for our speakers. Operator, can you remind our participants how to get into the queue for questions or comments? And I do want to apologize. The chat feature on our computer has not been working, so I have not been able to tell if there has been anything in chat or if people have been able to chat. So our apologies for that. Operator?
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 or the letter Q on your telephone keypad. If at any point your question has been answered, you may press 7 or Q again to disable your request. Please hold while we wait for the first questions. Our first question comes from Tammy Kroll. Tammy, please go ahead.
What is the actual role of the pharmacists that they play in this collaborative model with the physicians in the hospital? What impact are they actually having with the physicians?
Dan and Amanda, I'm going to leave that to you. You're the experts on that.
Yeah, so this is Amanda. I can speak and let me know if I'm not answering your question in the way that you were hoping. But, I mean, our pharmacists are really providing comprehensive medication management services. So they're meeting with patients individually. The physician, may have been the one to refer the patient. That happens in a majority of the patients that we see are self-referred from their physician. Maybe they weren't meeting their goals of therapy. Maybe they were having lots of questions about their medication. Or the physician oftentimes will refer the medication management to us, and they want us to help sort out the patient's medications and make sure that they're on the right regimen and start new medications to, again, help them achieve their goals. So our pharmacists do a comprehensive visit. They go through all of the medications and make sure that they're indicated, effective, safe, and convenient for the patient. They create a plan of care for that patient, and we follow up consistently. So they really integrate as another member of the team, working with the physician, talking about what was found during that visit. Again, we have collaborative agreements, so we're making a lot of changes when we see those patients, and really just incorporating as another provider member.
And the participants or the patients will come right to the pharmacy, or the pharmacy, you said, makes a visit? Do they go into the home to see how they're really managing their meds and how they're actually taking them?
Yeah, our pharmacists are actually all integrated into the clinic. And so the patient comes to the clinic just like they would to see their physician. Our pharmacists see the patients in exam rooms. We did have a home visit program and are actually restarting that program that we did for 7 years, where we could send pharmacists into the patient home if a patient was homebound or needed that. And we'll continue to do that in a complex care team that we're creating that will actually go and do home visits as well. But yeah, our pharmacists are not really in the community pharmacy space. We do have community pharmacies that are attached to our clinics, but the pharmacists actually providing this service are embedded into the clinic.
Thank you. It looks like we are at the top of the hour, and if you do have any further questions, please feel free to contact one of the state representatives there, and we can certainly pass your question on to either Amanda, Dan, or Todd. So this concludes today's educational session. Thank you again, Amanda, Dan, and Todd. All registered participants will receive a link to a short evaluation via email. Please take a minute to provide feedback on today's session. Once you've completed the evaluation, you'll receive a certificate of completion. There is one for general certificate of completion and one for pharmacy. You may have a copy of the certificate and provide copies to others participating today. This session was recorded and will be available at www.org in about 2 weeks. Thank you all for participating and have a great afternoon.
Thank you. This does conclude today's teleconference. We thank you for your participation. You may disconnect your line at this time.